Thank you so much, ma'am, for that very kind introduction, and thank you, Gautam sir, for inviting me here. It's such a pleasure to be part of the Yuva conferences of ISAR. I think they're fantastic and gives so much opportunity to us youngsters to present our views. I'm going to be talking about early pregnancy losses as an embryologist. It's a very different topic. And I hope to open a Pandora's box of discussion, especially with all the different add-ons and the controversies that exist with these add-ons. So we have to understand that when we talk about early pregnancy losses, most of them occur even before detection, even before implantation, and that's a factor that we have to understand and we have to try and rectify. So most clinically recognized pregnancy losses occur before 8 to 9 weeks. Most pregnancy losses after 8 weeks occur within the following 2 gestational months. And they reflect many factors, but there are 2 important factors that have significance. First is maternal age, that's positively correlated with pregnancy loss rate. And the second is basically a history of previous pregnancy losses. Now, whenever we think about pregnancy losses, 2 things come to mind. First of it is aneuploidy, and that's something that most of us think about, that if it's a pregnancy loss, it's probably because of aneuploidy. And off late, there is this new concept of sperm DNA which is creeping up, and which a lot of people also think that sperm DNA is now contributing to the early pregnancy losses. If you look at this triangle, we have to understand that it's estimated that almost 70% conceptions are lost prior to birth, and most of it are pre-implantation. So if you look at it, 30% is pre-implantation, 30% is post-implantation. Out of the remaining 40%, 10% are miscarriages, and then the remaining 30% is your live birth, which happens. Now, let's start with the first one, which is aneuploidy. Now, this is a very nice description of aneuploidies and early abortion. So these people looked at natural conception and IVF conception in less than 35 and over 35, and found out that trisomies were the most common cause of aneuploidy, followed by structural rearrangements within the less than 35 group. In more than 35 group, it was almost to the tune of 75% that it was resulting because of trisomies. What about IVF conceptions? Again, trisomies 60% in the less than 35 group, and over 80% in the more than 35 age group. Now, what causes embryonic aneuploidies? Lots of things can cause embryonic aneuploidies, right from DNA damage to meiotic errors at the time of fertilization, to mitotic errors at the time of embryonic division, fertilization errors, and also cleavage dynamics, and certain new concepts that are coming as far as the cleavage rates are concerned. Now, when we talk about origin of aneuploidy, like I mentioned, the first point of origin is the time of fertilization, and that is at the time of meiosis. And following that, you have mitosis, and even during mitosis, because of all the different factors that can affect the division, you can have embryonic aneuploidy, and you can also have mosaicism, which occurs because of that. This is a nice pictorial description of how it happens. You can actually see, so this is the presence of a micronucleus within a blastomere, and how it basically affects embryonic division. And it can actually cause, if it's a balanced error, it can cause one of the cells to actually become aneuploid. If it's unbalanced, you can actually have more cells becoming aneuploid, and this can also contribute to mosaicism and the percentage of mosaicism later on. And this is a beautiful paper which actually shows this in real time, where you can actually see that the chromosomes, how they are within the spindle, they will now try to segregate. They'll try to become 2, and then they'll become 2 cells. And you will be able to identify that there is a micronucleus that leaks out, and you can actually see it right there, trying to go back to the cell, but actually exists as a micronucleus later on. When we talk about mosaicism, again, there are two or three different patterns that can happen. So the first one, you can actually look at the top panel here. This is a normal division where you have a normal fertilization resulting in normal nucleation, followed by a no aneuploidy, no mosaicism situation. You can have a meiotic error where you have errors during fertilization, followed by abnormal nucleation, and you obviously have an aneuploidy later on. But then you can also have a mitotic error where during the process of cell division, there are certain cell lines which start exhibiting mosaic or start exhibiting aneuploidies, and it could be because of a single cell loss where you have a single a single blastomere could be mosaic. It could also be multiple blastomeres that could have the aneuploidy, and then you try and calculate the percentage. And this is one reason why PGT for day 3 embryos don't work, because we now need more cells to be biopsied so that we can actually calculate the percentage of mosaicism and then basically talk about it. I don't even know what to do with mosaicism. We can just talk about it. Now, what are the different chromosomal aberrations that can happen during early pregnancy losses? So these are studies from the abortuses, and they found out that the most commons are triploides. Then you have 69 XXX, 69 XYX, and the list goes on and on. Very nice list to actually have in order to try and explain to the patient what's going on. And this is another study which actually looked at the second abortus, and they found out that trisomies were again the most common in the second abortus, followed by monosomy, followed by triploidy. Now, how do we deal with this? We can do a biopsy, and if we're doing a biopsy, it has to be done at the blastocyst stage. I'm not going to be talking about other stages as of now, because that's now becoming one of the gold standards for PGT. But PGT itself has so many complications, and itself is so there's so much different varieties of evidences that exist with PGT that we still don't know whether PGT screening for aneuploidies is beneficial for patients or not. There are certain strengths, weaknesses, opportunities with PGT. I mean, it could decrease miscarriage rate, which is one of the topics that we are discussing today. But the weaknesses that are associated are basically very poor evidence, lack of RCTs. Again, the opportunity that exists with PGT is that you can do a single embryo transfer, you can reduce the time to pregnancy, and ultimately all it boils down to is whether it has a cost-benefit ratio for the patient or not. ASRM came up with the recommendations of PGT-A, saying that it could be used for women over 37, and that's the subgroup that it might benefit the most. But again, if you look at the evidence here, it basically says that miscarriage rate was significantly reduced, and the latest publication that has come up in the New England Journal of Medicine basically says that it is not improving cumulative live birth rates when the patient has more than 3 good quality blastocysts present for them. But again, that study is worth discussing, and I think we should have a discussion on that. I don't have it as a slide here because it came like 2 days ago, but worth a look. Okay, there are lots of recommendations on PGT-A. You already know that STAR trial exists, but basically what everyone is saying that there's only a very small subset of patients which might benefit, and most of them are now moving away from PGT-A in routine practices. Now, the next part is Morpho Kinetics. So, can Morpho Kinetics predict euploid pregnancy loss? And this is a nice paper which basically says that pregnancy loss is multifactorial, and just by looking at the Morpho Kinetics, we can't really predict whether an embryo is going to implant or not, and we can't really predict whether it's going to result in a miscarriage or not. What about mitochondrial DNA? This is again a new concept which a lot of people follow, especially with PGT-A, and basically says that mitochondrial DNA content is unable to predict miscarriages. What about sperm DNA? Now, sperm DNA has been shown to have a strong association, especially if done properly. So if you're doing a tunnel assay, that has a strong correlation with miscarriage association, but most of us don't do tunnels. We are still following SDF and staining, and that might not be the most accurate way of detecting sperm DNA fragmentation. When you look at the ESHRE guidelines, they do suggest that the male partner should be evaluated for a case of recurrent pregnancy losses, and we want to assess the sperm DNA fragmentation and it's a conditional recommendation that they have. Now, this has already been discussed. Once you detect something wrong within the male partner, what is there to actually do for the patient? So, zeta sperm selection, I think we had a the previous speakers talk about it, is the only sperm selection technique that actually has Cochrane backing it. But again, not many people know how to do it. We did have the protocol being discussed in the previous session, but again, it's something that not many people do it. What about Pixie? I think this was part of the discussion. So very low quality evidence to suggest that Pixie decreases miscarriage rates. This is Cochrane 2018. No effect of on live birth rate, and they do mention that it decreases miscarriage rates. This is in the Miller RCT, which was published in Lancet in 2019. So if you have that subset of patients which are suffering from recurrent pregnancy losses, then as part of the research setting, you could think about doing Pixie for them. What are the other things that we can consider as embryologists in the laboratory? Prognosis of the oocytes is something that we can look at, and there was this concept of looking at SCRs because they were the ones which were most associated with miscarriage rates, and then prioritizing embryos arising from such eggs is something that embryologists can do in order to actually improve the outcomes for patients. And it has been said that if you have multiple defects, obviously it's going to have poorer prognosis for the subsequent cycle. What about embryo morphology? There is an association between grade A quality ICM, and that's the least likely to cause a miscarriage. But again, it's not a very strong association that we are talking about. What about the cleavage rates and blastulation status? You can look at delayed blastulation and multinucleation. Both of them have certain associations with live birth rate, but again, this is something that needs to be followed up much better. Adjuncts in the laboratory, can we do something to actually treat such patients? There is actually no evidence for any of the adjuncts that we use to actually reduce miscarriage rates. So to sum it up, aneuploidy probably is responsible for a high percentage of early abortions. PGT is inconclusive as of now. PGT-SR might benefit where translocations are suspected. Sperm DNA has a strong correlation. Pixie might help in reducing miscarriages, and embryos arising from abnormal oocytes should be deprioritized. Now, this was a little bit about the factors that are causing. Now, there is another set of factors that can actually result in losses, which is something that we as embryologists can look at, and these are indirect causes. And this is basically what we are doing within the laboratory, because there are so many factors that can actually cause a lot of stress to the embryo, which can ultimately cause a poorer outcome, and that's something that we should be looking at. So we should be looking at air quality within the laboratory, we should be looking at the culture medias that we're using, the temperature loss or the exposure that can happen within the laboratory, the quality of the incubators, the quality of the oil, and these are all new things that are coming up, and these are things that are worth discussing. So there are studies to say now that embryo culture media does influence the development of children later on, and this is something like we were discussing, that we don't have any data on long-term consequences of whatever we are doing within the laboratory, be it PGT is very far. We don't even have long-term data for culture media or basically even embryo selection as such, and that's something that we now should shift our focus towards. And these are studies which basically say the same, where we're looking at ammonia buildup and how it's affecting the quality, and Gardner has done a lot of work on similar. We also have to look at the additives. So there are 3 different additives that we could focus on. So the first one is GM-CSF, very low quality evidence to suggest that it does better than regular culture media, not being recommended for use. New things that are coming up are antioxidants within culture medias to improve blastocyst quality and ultimately improve your outcomes. Both publications are from Gardner's group, the ones who are actually developing the media. So we have to take it with a pinch of salt that there is a bias that could be associated. But they've mentioned that it could benefit the subgroup patients between 35 and 40, and it could actually improve their outcomes. This is a nice sum up of all the different factors within the laboratory which can actually improve blastocysts. So you have to look at the gametes. 4 important things to look at when you talk about the gametes are exposure. You have to look at the age of the patient. You have to look at sperm morphology, in very nicely described in Casanova's paper, and you have to look at the quality of the eggs as well. As far as culture conditions are concerned, again, 4 important things. Uninterrupted culture seems to be beneficial. Low oxygen tension, having a complete culture suite, as well as oil overlay, and more recently, talking about heavy oils is something that we could think about. Inside the lab, low VOC, low ppm, low light exposure, and if it's a KPI driven laboratory, you're obviously going to have better outcomes. And as far as the embryologist is concerned, try and minimize the stress, time the procedures. Your biopsy skills or general embryology skills are important, and cryopreservation skills are also very, very important. So with this, I think we can basically end. I do have another load of slides here, but I think this basically sums up what I'm going to be what I intended to discuss today, and we can actually have a few questions and have the floor discuss them. So thank you so much for your patient listening.